Hey there, future nurses. Welcome to this comprehensive clinical explainer on musculoskeletal trauma. Look, if you are gearing up for your med-surg rotations, you already know that understanding the skeletal system is about way more than just memorizing a bunch of bones, right? Today, we're going to bridge that gap between textbook pathology and what you will actually see at the bedside. We'll be focusing exactly on what you need to know to assess, intervene, and actively advocate for patients experiencing severe physical trauma. Let's get right into it.
Take a look at this stark X-ray of a shoulder dislocation. I mean, wow. This is exactly the kind of structural failure you'll be assessing, stabilizing, and monitoring on the med-surg floor. When a patient rolls in with an injury like this, they aren't just bringing a broken or displaced bone. They are bringing excruciating pain, completely compromised mobility, and honestly, a super high risk for cascading complications. Your clinical reasoning? It's the absolute front line of their defense.
So, to keep our clinical reasoning razor sharp, here's our roadmap for today. 1. Sprains, strains, and dislocations. 2. Types of bone fractures. 3. Casts, fixation, and traction. 4. Managing critical complications. And 5. The bone healing process.
All right, Section 1. Sprains, strains, and dislocations. Let's dive into what happens when soft tissues and joints take the hit.
You know, it's pretty easy to just dismiss a sprain as a minor injury, but clinically, the spectrum is actually huge. A sprain specifically refers to tearing the ligaments right at a joint. Now, while a grade 1 sprain might just mean minimal swelling and no weird abnormal motion, as the nurse, you've got to recognize that a grade 3 is a complete tearing of those fibers. It dramatically reduces joint function, causes a ton of bleeding into the joint space, and absolutely requires immediate targeted intervention. Subluxation, on the flip side, is a partial dislocation. It's a structural displacement that usually means a provider has to perform a reduction under anesthesia, basically popping it back into place. So the big takeaway here is properly grading that severity so you can anticipate exactly what your patient needs.
Okay, here's your bread and butter nursing intervention mnemonic for sprains, RICE. But let's look past just the letters and get into the actual clinical parameters. First, rest the joint to protect that healing ligament. Then, ice it immediately. Specifically, you want to apply an ice bag for 10 to 20 minutes every 1 to 2 hours during the day for those crucial first 24 to 72 hours. Next up, compress. Use an elastic bandage and make it snug, but, and this is a big but, your nursing assessment must ensure you aren't accidentally cutting off their circulation. Finally, elevate that injured part to minimize all that painful swelling.
Moving right along to Section 2, Types of bone fractures. Let's shift our focus from the soft tissues to the bone itself.
There is just a massive variety of structural failures you'll see. I'm talking everything from closed transverse fractures, where the skin miraculously stays intact, to comminuted fractures, where the bone literally shatters into fragments. You'll even see green stick breaks, which are super common in our pediatric patients. The key thing to realize here is that each unique fracture pattern completely dictates the medical treatment plan. A clean, closed fracture? That might just need a closed reduction, which is manually realigning the bone without surgery. But an open, jagged, or highly comminuted break? That's almost certainly heading to the OR for an invasive open reduction.
Okay, Section 3, casts, fixation, and traction. Once the provider gets that fracture reduced, your priority completely shifts.
Comparing these two stabilization treatments reveals a really fascinating contrast in your nursing responsibilities. Think about a traditional cast for a second. Your job is to educate the patient that, hey, they're actually going to feel some warmth as this cast sets. But more importantly, you absolutely must protect a fresh cast from getting dented while it dries. Seriously, never place a fresh cast on a plastic surface or cover a drying plaster cast with a blanket, because uneven pressure can cause severe circulatory impairment and awful pressure injuries. Now, contrast that with an external fixation device, which we use for massive open fractures with extensive tissue damage. Because pins are going through the skin and straight into the bone, your job becomes meticulous, sterile pin site care to prevent devastating deep bone infections.
For slightly less invasive stabilization, we often use skin traction, like box traction shown here. This involves applying splints, bandages, or tape directly to the skin below the fracture, and then attaching weights. In a med-surg setting, your nursing assessment here is pretty much non-stop. You have to constantly verify that the patient's body alignment is proper in the bed. And this next part is absolutely crucial. You must ensure that those weights are hanging completely free. If the weights are resting on the floor or getting caught on the bed frame, the traction is broken. And trust me, the patient's muscle spasms will immediately pull those fractured bones right out of alignment.
In contrast to skin traction, skeletal traction setups utilize pins, wires, or screws placed directly into the fractured bone itself.
Because this is highly invasive and supports much heavier weights, your vigilance as a nurse literally has to double. You're monitoring both the mechanical integrity of the suspension ropes and pulleys and the incredibly high risk of infection at those insertion sites. It looks like a complex rigging system, and, well, it kind of is. Your thorough shift assessments are what ensure it functions perfectly to keep that bone aligned.
All right, we've reached the high-stakes stuff. Section 4, Managing Critical Complications.
I need you to burn these 6 Ps into your memory right now. We're talking about compartment syndrome, which happens when external or internal pressure restricts circulation within a muscle compartment. Look, if your patient reports severe, unrelenting pain that their prescribed narcotics just can't touch, you are very likely witnessing compartment syndrome. You need to immediately assess for pallor, paresthesia, that tingling pins and needles sensation, pulselessness, paralysis, and poikilothermia, which is just a fancy way of saying the limb feels unusually cold to the touch. Make no mistake, this is an absolute clinical emergency.
This visceral illustration shows exactly why those 6 Ps are a 5-alarm fire. You can see how massive internal swelling restricts the nerves and blood vessels inside that tight fascial compartment. Because the fascia just doesn't stretch, the pressure literally has nowhere to go but inward, completely choking off the blood supply. To save the limb from necrosis, a surgeon has to step in and perform a fasciotomy, which means literally slicing open the tissue compartments to relieve that pressure and restore blood flow.
But wait, there's more. Aside from compartment syndrome, your clinical radar also has to scan for other systemic threats. A highly vascular broken bone, like a femur or a pelvis, that can cause severe internal hemorrhage, leading to sudden hypovolemic shock. You've also got to watch out for fat embolism syndrome, where fat globules actually escape from the bone marrow, enter the bloodstream, and travel straight to the lungs. And on a slightly longer timeline, you really must advocate for your patient to avoid disuse syndrome. That's the creeping deterioration in muscle atrophy that happens from prolonged inactivity while stuck in casts and splints.
Finally, we arrive at our last segment, Section 5, the bone healing process.
Surprisingly, healing can sometimes go terribly wrong. A fascinating and frankly really painful example of this is heterotopic ossification. This is when bone literally starts growing where it absolutely shouldn't, like inside muscle tissue or soft tissues, instead of staying within the skeleton itself. It often happens after a hard hit to the soft tissue or severe trauma, and it's surprisingly common in young, active athletes after sports injuries. It absolutely destroys joint mobility, causes immense stiffness, and if that range of motion dysfunction persists, it might even require surgery to go in and remove the rogue bone growth.
But assuming healing goes well, you still have to educate your patient that this timeline is a marathon, not a sprint. While a hematoma forms pretty much immediately, and a protective callus resorbs and transforms into bone somewhere between 3 to 8 weeks, well, that's still not the end of the story. Complete consolidation and the remodeling of the bone so it can handle full mechanical stress again, that can take anywhere from 4 weeks up to a full year. And that depends heavily on the patient's age, their baseline health, and just how severe the injury was to begin with.
This sequence maps out that physiological timeline beautifully. We start with the chaotic, bleeding hematoma, which eventually transitions into granulation tissue. From there, we see the soft callus formation bridging the gap. Next up comes the osteoblastic proliferation, basically the body laying down new, harder bone cells, leading into bone remodeling. And finally, a united, fully remodeled bone that can actually bear weight again. Remember, your role is supporting the patient both nutritionally and physically through every single one of these stages.
So as we wrap up this explainer, I really want you to think about your role, not just in the acute, high-adrenaline emergency, but in the long-term recovery. What happens if a delayed union occurs, where the bone just refuses to heal on time, or worse, a non-union where it fails to unite completely? How will you empower a super frustrated patient when their body isn't cooperating? Will you be ready to explain cool interventions like 20-minute daily sessions of low-intensity pulsed ultrasound? Or maybe the possibility of a bone graft taken from their iliac crust to facilitate that final union? As a med-surg nurse, your deep understanding of this entire pathway is exactly what transforms a traumatic injury into a successful recovery. Keep studying, keep asking the hard questions, and I'll catch you in the next explainer.